Hello, and welcome to Equality Indicators Meets Women's Health. I'm Karina Jackson, and I'm Program Director for Community Service Council, Healthy Start in Tulsa, Oklahoma.
And I'm Melanie Poulter. I am the Data Manager for CSC's Healthy Start, and I am Research and Data Director at the Tulsa Area United Way. So we will start out today with a review of what equality indicators is, followed by the results of our application of equality indicators to a particular set of women's health indicators for the state of Oklahoma. Specifically, we'll be looking at women's health indicators that are directly related to maternal and child health. And then we'll discuss risk factors, root causes, and potential solutions for the disparities found in our analysis.
Our objectives are understand what equality indicators is, its purpose, and how it can be applied to any set of indicators, increase awareness of disparities by race for key women's health indicators, learn about risk factors and root causes contributing to disparities in women's health, expand awareness about potential solutions to disparities in women's health, including practices of Healthy Start.
So a little bit first about equality indicators. Equality indicators is a framework for analyzing data that is used to measure the level of inequality or disparity in outcomes or opportunities between two groups of people, usually the most and least advantaged populations in a particular city or a state. It has several purposes. It is meant to be used by city leaders and other community leaders to identify areas to focus equity efforts, to guide public policy development, to reduce inequalities, to inform solutions that lead to improved outcomes and opportunities with a focus on equity, and to identify trends reflecting impact of changes in policy and practices. If you'd like to learn more about Tulsa Equality Indicators, the website is tulsaei.org. So our analysis that we're sharing with you today involves the application of the Equality Indicators framework to a number of women's health indicators. And what this tells us is not how Oklahoma women are doing overall on these various indicators, but rather what the disparity is between different groups of Oklahoma women in each of the areas we address. So before we get into talking about the results of our research, I want to explain a little bit about what I'll be showing you for each of the 11 indicators we analyzed. The bar chart on each page shows the raw data for each major race and ethnic group, with the population groups used to calculate the equality score highlighted in red. Then we show you the ratio derived from the comparison of the two population groups and the equality score based on that ratio. This score ranges from 1 for the greatest level of inequality to 100 for total equality. We are starting with several indicators that are social determinants of health, beginning with poverty rates. So before we even start talking about disparities among females based on race and ethnicity, let's first acknowledge that women are 18% more likely to live in poverty than are men, and that women supporting single-parent families earn 27% less than men supporting single-parent families in Oklahoma. Beyond that disparity for all women, women of color experience poverty at greater levels than do white women in Oklahoma. African-American females have the highest rate of poverty in Oklahoma at 30% compared to white females at 13%. This means that African-American females live in poverty at a rate that is 2.3 times that of white females. Comparison of these two populations gives us an equality score of 38 out of 100. Based on self-reporting, Oklahomans overall have some of the highest level of adverse childhood experiences, or ACEs, in the nation. Our research finds that nearly 1 in 3 Native American women have had 4 or more ACEs, compared to about 1 in 6 Hispanic Latinx women in Oklahoma, meaning that Native American women are almost twice as likely as Hispanic Latinx women to have 4 or more ACEs. This results in an equality score of 45 out of 100. Going hand in hand with our state's elevated rate of ACEs, Oklahoma incarcerates women at a rate higher than all but one other state in the nation, which is Idaho. And it's not that Oklahoma is home to more criminals, but that we have a more punitive approach or philosophy toward criminal justice. Our review of arrest rates of females by race and ethnicity reveals that African-American females are almost 2.5 times as likely to be arrested as our white females in Oklahoma, for an equality score of 38.
So what we see in Healthy Start participants with the arrest history, they get mostly arrested for survival type activities or situations. And these are individuals that are trying to meet a basic need, or just out of desperation, or just simply want to do something for the family, and with their funds for the family, it doesn't weigh importance over what they believe in for as their health.
So women with a personal doctor or other healthcare provider are more likely to receive consistent preventive healthcare than those who do not. Our research finds that Hispanic Latinx women in Oklahoma have the lowest rate of having a healthcare provider at 58%, while white women have the highest rate at 85%, and almost 50% higher rate, for a score of 62. Healthcare costs seem to continue to rise, making it harder and harder for some individuals to afford even basic medical care. When you're earning just enough to pay the bills, or even less, a visit to the doctor just doesn't fit into the budget. Too many Oklahoma women are doing without needed care due to high cost. 3 out of 10 Hispanic Latinx women have gone without needed medical care due to high cost, compared to 14% of Native American women, for a score of 39. The behavioral risk factor surveillance system uses the measure of 14 or more mentally unhealthy days per month as an indicator of mental distress. 14 plus days per month is strongly associated with the diagnosis of mental disorders such as depression and anxiety. About 1 in 5 Native American women report 14 or more mentally unhealthy days per month, compared to about 1 in 7 Hispanic Latinx women in Oklahoma, meaning that Native American women are about 50% more likely than Hispanic Latinx women to have mental health disorders. This disparity generates a score of 62. Shifting now to indicators that are specifically and directly related to maternal and child health, we start with a share of women giving birth who received adequate prenatal care, which is defined as beginning care during the first trimester of pregnancy and having at least 10 total prenatal care visits. Prenatal care is considered a key contributor to birth outcomes. We find that there are not major differences by race and ethnicity in Oklahoma, but at 49%, African-American women are a bit less likely to not receive adequate prenatal care than women of other races. So for comparison, about 61% of white women receive adequate prenatal care in Oklahoma, for a score of 73.
So what we see in Healthy Start a lot of the times is those clients that are higher in risk, such as smoking or overweight or pressing issues, delay their prenatal appointments when they find out that they're pregnant. And then a lot of their concerns wrap around the Maslow hierarchy chart, which is health is not important to me. Other defined issues and situations that I'm going through are more important than health.
So preterm births are live births occurring prior to 37 weeks gestation and is one of the primary direct causes of infant death. Preterm birth increases the likelihood of developmental delays and other long-term health problems. African-American women in Oklahoma are almost twice as likely to deliver a baby preterm as are Asian women at a rate of 15.3% and 8.7% respectively, for a score of 50.
So what we see in Healthy Start is that stress is hereditary. It links to inadequate prenatal care, not being fully educated about best practices during pregnancy to prevent preterm births.
Low and very low weight births are defined as babies weighing less than 5 pounds 8 ounces and 3 pounds 4 ounces respectively at birth. Preterm birth is one of the most common causes of low birth weight. African-American women are more than twice as likely as women of any other race in Oklahoma to deliver low or very low weight babies for a score of 40. Infant mortality is the death of an infant before his or her first birthday. These rates refer to the number of infant deaths per 1,000 live births. Infant mortality rate is not only an indicator of maternal and child health, but is also commonly used as an indicator for the overall health of a community. Women of color in general are more likely to experience the death of an infant than are white women, but African-American women specifically experience the loss of an infant at a rate nearly 2.5 times that of white women, giving this indicator a score of 38. Research indicates that even when socioeconomic health and prenatal care factors are held constant, African-American women in the United States experience greater levels of infant mortality than women of other races. A growing body of research links this persistently higher rate to maternal stress levels, specifically stress related to racism, individual and personal racism, continuing structural, systemic racism, as well as historical racism, effects of which can be inherited.
So what we see a lot of the times is a system that is built for white women. Basically, African Americans do not have any say-so, and that's just not even just with women, but also fathers too, and the fathers of those families. And often you will see systems built with non-white other races that are not taken in consideration. Their feedback is not taken in consideration.
Maternal mortality is the death of a woman while pregnant or within 42 days of the end of pregnancy from any cause related to or aggravated by the pregnancy or its management. African-American women are at least twice as likely to die due to pregnancy or pregnancy management as are women of any other race, but they are 12 times as likely as Hispanic Latinx women to do so. This disparity produces an equality score of 1, the lowest score possible.
So what we see in our African-American clients in Healthy Start is that those clients are not healthy before they become pregnant. They're dealing with stressors. They're dealing with doctors not listening to their feedback. They think that sometimes we hear that the provider is actually not taking their symptoms and their complaints seriously. And that, you traditionally see sometimes that there's a taboo in the African-American community that we don't like surgery. But we also see the fear and the history of poor medical treatment, Medicaid coverage. Patients may not receive receive less through care than private insurance covering patients in the African-American community learns to ignore their medical concerns in general.
So together, these 11 indicators of women's health produce an equality score of 44.2 out of 100. This score reflects the extent of inequality among different population groups in Oklahoma in the area of maternal and child health. So now we're going to dig into both individual and systemic risk factors that directly contribute to these disparities and root causes that underlie and drive these and many other disparities experienced by population groups in Oklahoma. Then we'll shift to potential solutions.
So what we see is individual risk factors such as tobacco use, substance abuse, obesity, domestic violence, inadequate prenatal care, untreated stress, depression, mental illness, lack of primary health care providers and preventative health care, and delayed concerns about pregnancy and birth outcomes. Systemic risk factors include exclusion from decision-making, inadequate or poor access to preventive health care, culturally incompetent, rude, or disrespectful, healthcare providers and staff, past due medical bills, inadequate wages, lack of affordable housing, food deserts, and transportation barriers, negative police contact. Our root causes include lack of trust in medical profession, avoidance of standard health care, lack of inequitable representation in creating and operating healthcare systems, historical trauma, lack of acknowledgement of history, culture, traditional and historical and present racism. Solutions. I love to talk about solutions because I feel like I've been in Healthy Start for 23 years, and these are 3 of my grandbabies that are part of a good solution. And part of that was culturally competent and compassionate health providers and staff. We talk about eliminating barriers, diversity in healthcare field, build trust with the patients, and destigmatization, I cannot pronounce that word sometimes, of acknowledging and seeking treatment for mental health problems. Those are 3 of my grandbabies. Shamara is in the eggplant dress. She is now 10. And then we have Butter Muffins, who is chewing on the cookie over there in her red dress. She is now 5. And Shanice, which is my youngest one, and she is now a year old, are all part of Healthy Start and was in Healthy Start when my daughter got pregnant and delivered, all 3 of them. Part 2 of those potential solutions is inclusion of women and including women of color in decision-making and creating solutions. We do that quite often. Feedback from the care coordinators and also the clients that we serve. We generally have focus groups to capture that information. Creation and implementation of equitable practice and policies, elimination of racist practice and policies, healing from racism on all and every level, and community-based participants and participation in research, living wages, and inadequate affordable housing.
So we thank you for sharing your time with us today. And our contact information is on this slide if you would like to reach out to either Karina or I to talk about Healthy Start or equality indicators. We hope you have a great rest of your day.
Thank you.